nuclear bases. So that's why we say that methotrexate can also inhibit the de novo synthesis, that is synthesis from scratch, de novo synthesis of nuclear bases, especially the purine bases. So that's the pathway that is involved. Now we can look at some other agents, like your capecitabine. Capecitabine is one of your pyrimidine analogs that will be converted to 5'-deoxycytidine, and that 5'-deoxycytidine can go to 5'-deoxy-5-fluorouridine, which can eventually be converted to 5-FU, and then you get the production of your FUDUMP, fluorodeoxyuridine monophosphate, and that FUDUMP will inhibit your thymidylate synthase, so it cannot form DNA. Okay, so that's one pathway or that's the mechanism of action for capecitabine. If we look at another drug, like say gemcitabine, which right here number 6, gemcitabine can work at 2 levels. When you give gemcitabine, because it is a nucleoside, it has to be converted to its nucleotide form. Okay. And it can be converted to the dinucleotide form, and that dinucleotide, that is gemcitabine dinucleotide, is the one that would inhibit RDR. So in the di form, it inhibits ribonucleotide diphosphate reductase, but it can also go to its tri form, that is which will be a nucleotide, and the tri form is the one that would inhibit your thymidylate synthase. So gemcitabine has 2 points of action. In the dihydroxy form, or in the dinucleotide form, it can inhibit ribonucleotide diphosphate reductase, and then in the tri, it can inhibit thymidylate synthase. That's another drug that inhibits that RDR, the drug hydroxyurea. Hydroxyurea is an inhibitor of RDR, or ribonucleotide diphosphate reductase. Okay. And we've mentioned that hydroxyurea is used for your granulocytic leukemia, chronic granulocytic leukemia, or what you call CGL, chronic granulocytic leukemia. And like I mentioned earlier, you don't have to get a malignant tumor, that is a malignant form of leukemia, for hydroxyurea to work. If you just have an excessive increase in your leukocytes, so basically leukocytosis, you can also use hydroxyurea to bring the levels of your leukocytes down. And the drug is also used in sickle cell anemia. So hydroxyurea also works for your sickle cell anemia. In the beginning, it was very, very effective, and then eventually the effectiveness just dwindled. but it is still one of the drugs mentioned for sickle cell management. So that's another drug that works in this pathway. And all of these were available as drugs, fluorouridine by itself, and then fluorodeoxyuridine. And that's why I listed them under the pyrimidines over there. So those can work. Even this agent, 5'-deoxy-5-fluorouridine, that was also available as a drug. So 5'-deoxy-5-fluorouridine, fluorouridine, and fluorodeoxyuridine. All those will work along this pathway. In other words, they would eventually get converted to 5-FU, which can then go down that pathway to give you your fluorodeoxyuridine monophosphate, that is for dump, which can then inhibit amylase synthase and thereby inhibit DNA synthesis. Okay, so for capecitabine, we've seen its pathway, its mechanism of action. It can be used for the treatment of head and neck cancer. So you can use it for head and neck cancer. It can also be used for breast cancer, of course, and it can also work in ovarian cancer. So it's also helpful with ovarian cancer. Okay. Okay. If we look at its adverse effects, let's see. The adverse effects that stand out, regarding your capecitabine. Trying to put another one there. That would be your stomach cancer. It's very, very effective in stomach cancer. Okay. If we look at the adverse effects of your capecitabine, it can produce what is called foot and hand syndrome. But that is clinically, you will refer to that as your palmar, that is the palm, that's hand, and pedal, or so this will be your arm, then this will be your plantar, like you're planting your foot. So it will be palmar, plantar, erythrodysesthesia. And from the name, of course, you will see that it has to do with red blood cells, so there will be a lot of redness. It has to do with the hand and the foot, and the dysfunction, that, when you say this, a dysfunction that can cause that pain, or like pain pricking effect. Okay, so that's a major adverse effect of that drug, a standout adverse effect. It can also give you some other skin-related adverse effects. Okay. Such as rash and alopecia, erythema. They give you a little erythema, redness of the skin. And you can also see desquamation. Desquamation of the skin, which basically means you'll see the skin kind of scaly or you know, it can be sort of dry and itchy, and then it forms scales and it peels off. So scaling and peeling can be seen with this drug, you know, for that desquamation. And apart from this, it can give you some of your non-specific GI adverse effects: nausea, vomiting, diarrhea, stomatitis. All of those can be seen with that agent. And it may also affect the bone marrow. So that you can see things like thrombocytopenia, anemia, leukopenia, and all that. It may give you all of those adverse effects. You may also see some, I don't know if you mentioned it earlier, but that is common. They give you some alopecia. Okay. Then on the cardiovascular tissue, you may get a little MI, myocardial infarction, and some decrease in the flow rate of your cardiovascular or cardiac blood vessels. So all of those can be present with this agent, and it may even give you cardiac shock or cardiogenic shock. Cardiogenic shock may be a manifestation of the adverse effects of that drug. Okay. With your gemcitabine, quickly look at gemcitabine, which is the other agent we highlighted there. So we've seen the mechanisms of action of gemcitabine: RDR inhibition at the di level, and then at the tri level, it can go to the inhibition of your DNA synthesis. So with gemcitabine, what you can use it for, it can be used for pancreatic cancer. It can be used for mesothelioma. Okay. Mesothelioma. And mesothelioma is sometimes called your malignant pleural mesothelioma. You know, when it's cancerous. So malignant pleural, as in the chest cavity, malignant pleural mesothelioma. So one can use gemcitabine for that. So pancreatic cancer, mesothelioma would be another one, and it can be used for non-small cell lung cancer, NSCLC, non-small cell lung cancer. So it can be used for that. Of course, it can be used in breast cancer management and ovarian cancer. It is also effective in there, and cancer of the bladder, as well as cancer of the bile duct. So it is useful in all of those situations, and it can also be used for the management of PTCL, which means peripheral T-cell lymphoma, peripheral T-cell lymphoma, and it also works in CTCL, which would be cutaneous T-cell lymphoma. So it's a very versatile agent, that gemcitabine. In terms of the adverse effects that it produces, it can give you a condition that is called HUS, hemolytic uremic syndrome. Hemolytic uremic syndrome. And gemcitabine is not the only agent that causes HUS. You have some other drugs that can produce that condition. So you have gemcitabine, and 5-FU can also cause that HUS. Cocaine can also produce that HUS. Cisplatin. Cisplatin is known to do that. Cyclosporin would be another agent. Bleomycin may also cause HUS or HUS. Mitomycin is another agent that can produce that HUS. So you have many other drugs that can cause hemolytic uremic syndrome. So that's one major adverse effect. And two, it can cause like an increase in sugar, hyperglycemia. You see it with gemcitabine as an adverse effect, and it can also elevate your liver enzyme, AST, and you may also see an increase in bilirubin. So hyperbilirubinemia may also be produced by this agent. And it can cause a decrease in your magnesium and calcium. It can also cause a decrease in blood pressure, but sometimes it causes an increase in blood pressure. So those can be seen with this with this agent, it can affect the pulmonary system. It can cause edema. It may begin with your peripheral edema, and that can then lead to your pulmonary edema. So PE, pulmonary edema, and then you can have your ARDS, acute respiratory syndrome, or respiratory distress syndrome. Acute respiratory distress syndrome can be caused by your gemcitabine. And of course, being an anti-cancer agent, you can expect some alopecia with this drug, and then your bone marrow depression. Your bone marrow depression, so you're talking about the thrombocytopenia, anemia, leukopenia, pancytopenia. So all of those can be seen with this agent. And then it can affect the capillaries. There's something called CLS, capillary leak syndrome. You know, or you say some people use leakage, capillary leakage, but it's capillary leak syndrome. So you have those capillaries, those small blood vessels leaking out. So you're losing a lot of fluid, initially to the tissues within the body, and that's probably a cause for that peripheral edema that you see with gemcitabine. But that is always a serious situation. So those are some of the main adverse effects of your gemcitabine. And of course, it's administered orally, so you expect a lot of GI adverse effects with that drug. Nausea, vomiting, diarrhea, stomatitis is there sometimes. Stomatitis can be can be seen with your gemcitabine. Okay. So now we can look at 5-FU as a main drug representing the pyrimidine nucleosides. So 5-FU we know the mechanism of action because we've done that. In terms of its ADME, the drug can be administered orally. It can also be given IV. It can be given topically. The PO form is seldom used because absorption from the PO form is very erratic. You would not know how much you could get into the system. So that is seldom used. Actually, the only time that it is used is if the patient has like stomach cancer and they won't tolerate any other route of administration for some reason. but it can be given orally. But most of the time it is administered IV, and you give about 12 milligrams per kilogram IV, and that's on a daily basis for 4 days, and that is repeated every 30 days. Okay, so 12 milligrams per kilogram IV times 4 days, and that regimen will be given every 30 days. Okay, because 5-FU can be used by itself in certain conditions. For instance, in bladder cancer, and also in ovarian cancer, it can be used by itself as a single agent. But most of the time it is administered in combo or combination with other drugs. So it can also be given topically. When it is given topically, you can say a product like, say, Epidex. That's a topical use of your 5-FU. There's a product called Accusite. Okay. So Accusite is used only for one thing, and that's for genital wart. For genital wart. It's a gel. It's a gel form of your 5-FU. What you will say will be condylomata acuminata. That's the clinical term for your genital wart. Okay. Condylomata acuminata, and that's why you see that acu as the name of that drug, acuminata, even though single C. But anyway, so when it's given topically, it can be used for the management of that genital wart or condylomata acuminata, and it can also be used for pre-cancerous lesion. To prevent that lesion from progressing to cancer, to malignancy. It can also be used topically for keratinic lesions. Okay. So that is another indication for the topical use of your 5-FU. Sometimes one can see it used in your peripheral B-cell carcinoma, peripheral BCC, peripheral B-cell carcinoma. So that's another use of topical form of your 5-FU. So those are some routes of administration: IV, PO, and topical. Okay. So that's in terms of routes of administration for your 5-FU. And we know that the half-life of 5-FU is very, very short. It is anywhere from 5 to 20 minutes. So it has a very short half-life. And the half-life actually happens to be dose dependent. The more of 5-FU you use, or the higher the concentration, the longer will be the half-life of your 5-FU. So it's dose dependent. Anyway. And the plasma protein binding is also very low. You know, it's about 10% plasma protein bound. Knowing that, then one would know that it would have a very wide distribution since it is not bound to plasma protein. So it can be distributed to the breast, to the lungs, to the liver, you know, to the placenta, and also to the CSF. So it has a very wide distribution, which is good, because if you take, for instance, breast cancer, when you have breast cancer, one of the places that it can metastasize to is the bones. You know, that's actually one of the first places it would go to, is the bones, and the next place is the liver. And you know, this drug 5-FU can be widely distributed to all those areas. If we look at, I wouldn't say metabolism, I would say catabolism. If you look at the catabolism of 5-FU, this is the way it goes. The catabolism occurs in the liver, but the anabolism, that is the activation of 5-FU, is inside the cancer cell. Okay. So catabolism going this way, that occurs in the liver. And 5-FU can eventually be converted to what we call FUBOL, alpha fluorobeta alanine. Alpha fluorobeta alanine. And once that is produced, then it can eventually produce some carbon dioxide and urea. Okay. And then the carbon dioxide can go out through the pulmonary system. That is expiration. 90% of the catabolized 5-FU goes out through the expiration pathway, through the pulmonary system. So that's how you throw it out. The rest of it, of course, will go out through the renal system. And that's usually a low concentration. So it can go out through the pulmonary system, and it can go out through the urinary system. So that's in terms of ADME. Okay. And if we look at the adverse effects before we come to indications, the adverse effects of 5-FU. The TLT for 5-FU is bone marrow depression. That's the main TLT. That's what will make you stop the use of 5-FU. It's bone marrow depression. And the manifestation can be all the things that we've talked about, you know, thrombocytopenia, anemia, leukopenia, pancytopenia, all of those can be present. Okay. If you give too much of 5-FU, then you can use Vistogard as an antidote to excessive amount of 5-FU being administered. So Vistogard is an antidote to overdose of 5-FU. Okay. Now, 5-FU, as we mentioned earlier, can produce or cause hemolytic uremic syndrome, HOS. Okay, we rub that off. But anyway, 5-FU is one of the drugs that can cause HOS. And you can manage or treat that HOS by giving eculizumab, which is a monoclonal antibody, eculizumab. So eculizumab is useful in the treatment or management of HOS. That drug, eculizumab, can also be used to treat PNH, paroxysmal nocturnal and you will get your hemoglobin, excessive amount of hemoglobin being produced. Paroxysmal nocturnal hemoglobinuria, that will be going out in the urine. Which is a very deadly condition. The only thing that actually helps in managing PNH is just that drug, eculizumab, and it did not come out when it come out the market right around 2010, somewhere there. But anyway, so you can use that drug for HOS, you can use it also for PNH, and if a patient has myasthenia gravis, eculizumab is also effective in the management of that gravis, myasthenia gravis. So, use eculizumab for that and for the management of HOS. Okay, so those are some of its adverse effects. Then you can talk about the CNS related adverse effects of the drug. Remember, we said it has a very, very low plasma protein binding, about 10%. So it gets into the central nervous system very easily. Okay. And the major manifestation of its CNS adverse effect is that acute cerebellar syndrome, or ACS. Acute cerebellar syndrome. So, and how would you know if the patient is having ACS? One, they will have headaches, they will have confusion, they will have convulsion. Those three will be there. Then they can have weakness, muscle weakness, and you can see lethargy. They'll be lethargic, and they can have or experience or show malaise. Malaise is another manifestation of your acute cerebellar syndrome. Okay, so that's how you would know if that situation is occurring. So that's the CNS manifestation or CNS adverse effects of 5-FU. It can have some CVS related adverse effects, cardiovascular system. And the major thing there will be MI, myocardial infarction, and you can have some angina. As the cardiovascular related adverse effects. Then number 5 will be the effect on the eyes, because your 5-FU can cause lacrimation. So even though the patient does not want to cry or anything, but tears will be rolling down their face or eyes, if you will. So lacrimation is an adverse effect of that drug. Double vision, that is diplopia. Double vision will be another manifestation of the adverse effects of 5-FU on the optical or the eyes. So you can say that. Nystagmus can also be a manifestation on the eyes. You can even see photophobia as a possible adverse effect there. And there will be a general visual impairment. And sometimes it can even include problems with discerning colors, or what you will call chromatopsia. Color. So chromatopsia, you can see with your 5-FU. And just like you saw with your digoxin when you were treating or discussing your cardiac glycosides, the chromatopsia here is also usually for green and yellow. For green and yellow, that's the patient will not be able to discern those colors very, very easily. So those are the adverse effects that are related to the eyes. 6 will be adverse effects on the GI tract. On the GI tract, we'll talk about the usual, the regular ones: nausea, vomiting, diarrhea, dyspepsia, sometimes stomatitis, and you do get hemorrhagic enteritis. So we will say enteritis or gastroenteritis to be perfectly clear. So gastroenteritis, and that can lead to bleeding from the GI tract. So the stool from that patient can be dark, because of bleeding into the stool. That is, melena can be seen. Okay, and that's on the GI. On the skin. On the skin, you can see hyperpigmentation. That is, the skin becomes darker. Okay, hyperpigmentation, and the patient may actually experience nail loss. you know, so the skin will be darker and they can lose their nail, and you can get the hypersensitivity to sunlight. Okay. So photosensitivity can be seen with your 5FU. Can be. You, of course, you the things like rash, alopecia, dermatitis, all of those can be present, along with your photosensitivity. Those will be all the actions on the skin. Then some miscellaneous things. The patient may experience fever, and then you may get some patients who will be hypersensitive to 5FU, so hypersensitivity to 5FU can be present. And then another bleeding condition, epistaxis, nosebleed. Nosebleed may also be observed as an adverse effect of your 5FU. Okay. So now we can look quickly at the indications. Now, with all those adverse effects, you can prevent them from happening within normal cells by giving what we call a rescue agent with your 5FU. The rescue agent is leucovorin. Okay? So there's a difference between using a rescue agent and using an antidote. Okay. For the antidote, which we talk about, Vistogard, you have given too much, okay, and you just want to prevent toxicities. With the rescue agent, you're trying to prevent normal cells from being destroyed by the drug. Okay, so it's a difference between using a rescue agent like leucovorin versus using an antidote, in which case you're trying to reverse the serious adverse effect that resulted from excessive amount being given. So now for indications. Let's see how to rub some of these things off. Okay. Can clear this up. Okay, let me start from here. Okay, we have seen some non-cancer indications that we talked about when you use 5FU topically. So those will be non-cancer indications. But for cancer indications, one, we can talk about breast cancer. So it can be used for breast cancer, ovarian cancer, okay, cancer of the bladder, cancer of the cervix, so cervical cancer can also be It's there. Head and neck cancer. You can use 5-FU in such a situation. You can also use 5-FU in pancreatic cancer, and it is also effective in gastric or stomach cancer, as well as in colorectal cancer. So you can use 5-FU in those situations. We've talked about the combinations for breast cancer. Okay, talked about those before, but some newer combos, if you will, for which you can use combination drugs to manage breast cancer. You can use Herceptin in combination with pertuzumab. So trastuzumab plus pertuzumab. You can use that, and you can use a combination like HPT, in which case you just add Taxol to that Herceptin pertuzumab combo. Or you can use Herceptin in combination with Taxotere. Or you can use Herceptin in combination with Taxotere, and then you can just use carboplatin. So those are some relatively newer combos for breast cancer. So that's all we're going to say about that. And you can just use your Herceptin with Taxol. That is also used in managing breast cancer. Herceptin with Taxol, HT. Ovarian cancer, we've also already mentioned those. So breast and ovarian. For cancer of the bladder, the combo that you use for bladder is very similar to the combo that you use for ovarian cancer. So the main compound there is your cisplatin. So one can use what you call CMV or cis-MV, or you can use cis-MVA. That can be used. 6-tax can be used, and you can use cisplatin in combination with taxotere. This will be taxol. This will be taxotere. That combination can also be used, or you can just call your cisca. Cisplatin, cytoxin, that is cyclophosphamide, plus adriamycin. Cisca. And cisca is all of these are also useful in ovarian cancer. So you can use cisca. And if you look at all of those, you see that there's no 5-FU in there. And that's why I mentioned earlier that you can use 5-FU as a sole agent for treating, cancer of the bladder. And you don't see 5-FU as part of the combinations here. So it can be used alone in bladder as well as in ovarian cancer. Okay. Cancer of the cervix, one can use the MOB-CIS regimen. We can use the carbo-CIS regimen, or you can use that is 2 platinum compounds. You can use the carbo plus taxol, that. And you can use 5-FU, so it's in here. 5-FU in combination with cisplatin, the one that some people call FU-cis. 5-FU cisplatin. So all of those are effective in the management of cancer of the cervix. Okay, for head and neck, for the head and neck cancer, you can use the carbo regimen. That's useful. You can use the CFC regimen, and then you can use the CF, two different regimens. You can also see the OFF regimen being used. See the MF regimen being used. Okay. For the carbo, Amitriptyline is another name for methotrexate. Okay. This is the same as MTX. So for carbo, you'll be talking about cisplatin. In this case, cisplatin. And the A here is actually methotrexate because it is amitriptyline. Okay, methotrexate, and of course bleomycin and your oncovin. Okay. For CFC, the C here is carbo. It's carboplatin. Carboplatin, your 5-FU. And the C here is cetuximab. Cetuximab. And then the first CF here, you can say carboplatin plus 5-FU, and then cisplatin plus 5-FU, okay? And then off will be oxaliplatin. Oxaliplatin plus 5-FU, and then with your folinic acid. Oxaliplatin, of course, one of your platinum complexes. Okay. Oxaliplatin plus 5-FU plus folinic acid. Folinic acid, as we've shown up here, okay, that's your rescue agent. That's your leucovorin. So one can use, and then MF will be methotrexate plus 5-FU. So that can be used for your head and neck cancer. And pancreatic cancer, well, there are older regimens that you use for head and neck. Those are the ones that would call, with my baseball cap, so on. MBC, baseball cap, and then on the cob, and map, CF, football league, and then MF. That's a bunch of some older regimens that you use for head and neck cancer. The only one that's a little off there is the A. Is the M in MAP, which is mitomycin. Okay. And the others you can very easily tell. The L here will be leucovorin, the rescue agent, leucovorin. So the cisplatin with 5-FU with leucovorin. Okay, so that's head and neck. For pancreas, some combinations that one use in pancreatic cancer will include FMIS, and you can say off, and FOLFIRINOX is another one that is commonly used. GEMOX. GEMOX is also used for pancreatic cancer. And whenever you say pancreatic, you always want to mention streptozotocin, one of your alkylating agents, one of your nitrosoureas, okay, streptozotocin. And so you have streptozotocin plus doxorubicin, and then you have streptozotocin plus doxorubicin plus 5-FU. SDF. So all of those work in pancreatic cancer. Fluorouracil, mitomycin, okay, and streptozotocin. Okay, and then off, we've already mentioned there, oxaliplatin with your 5-FU, and then with the rescue agent, folinic acid. For Ferinox, you break it like that, like that. That should be X. For Ferinox, so folinic acid, the rescue agent, and then 5-FU, and then irinotecan, and then oxaliplatin. So irinotecan, and then oxaliplatin, Gemox, gemcitabine, and oxaliplatin, and then streptozotocin, doxorubicin, streptozotocin, doxorubicin, and 5-FU. So those are combinations that are very good for pancreatic cancer. For stomach cancer, let's see. For stomach cancer, we often talk about FAM and FAME. Face, and then ELF. All of those can be used, or you can combine cisplatin with capecitabine with trastuzumab. Okay, or you can take irinotecan and combine it with, say, cisplatin or with capecitabine or with 5-FU. So those are regimens that are known to work very well in gastric cancer. One can also use FAMTX. So you have your methotrexate being used here for uracil, adriamycin, methotrexate, for uracil, adriamycin, and MA will be methotrexate, which is also like this FAMTX. Face will be fluorouracil, cyclophosphamide, and then you can use etoposide right there. Etoposide plus leucovorin plus 5-FU, and then the rest are self-explanatory. So that will be for your stomach cancer. And then for colorectal cancer, you can use first, you can use fecal. That's your rescue agent, leucovorin. And you can use ILF, and then Capox, that's capecitabine with oxaliplatin, and Zelox, because the brand name for capecitabine is Zeloda. That's why you have Zeloda with oxaliplatin, which is the same as your capecitabine with oxaliplatin. And then you can use folfiri. So, same way, folinic acid, and then 5-FU, and then irinotecan, folfiri. And for your folfiri or Capox or Zelox, you can always add bevacizumab. You can always add bevacizumab because bevacizumab is an inhibitor of angiogenesis. So it can inhibit the movement of your cancer from one tissue to another. But bevacizumab is an inhibitor of VEGF receptors, vascular endothelial growth factor receptors. Okay. Cetuximab is another agent that you can add to, all these Capox, Zelox, or even folfiri. Cetuximab also has some angiogenetic effect. So all those are good for colorectal cancer. And dostarlimab is an agent that we know can give you 100% cure rate in your colorectal cancer. So dostarlimab, D-O-S-T, dostarlimab, can give you 100% cure rate in colorectal cancer. All right. So now we can finish up the anti-metabolites by just quickly mentioning some agents in the purine derivative group. So everything we've done so far dealt with 1 to 9 in that group. But let's just quickly mention some other members of the group. So the first 6 are okay. Decitabine and azacitidine. Those are actually chemically related drugs. They're chemically related drugs. Azacitidine is used for, and I should say azacitidine and your decitabine. They're used for basically the same thing. You can see them used in AML, acute myelocytic leukemia, and they can also be used for MDs. And that's myelodysplastic syndrome. Myelodysplastic syndrome, MDs. The syndrome just involves things like anemia, you know, easy bruisability. The patient can bruise very easily, easy bruisability, you know, and then severe infections. Those are the three main manifestations of that MDS, myelodysplastic syndrome. And azacitidine as well as your decitabine very good for that condition. Individually, you have to combine them with anything. So, very good. AML, acute myelocytic leukemia, you can use your decitabine in combination with ARC, arabinoside cytidine. That's what we have here, the one that we mentioned under your antiviral agents. So RC can be used for viral infections. It can also be used in your acute myelocytic leukemia treatment. So you can use ARC plus your decitabine, or you can use RC plus azacitidine. You can also use that RC and combine it with your Vinolect, Venetolax. Okay. Venetolax is a compound that inhibits BCL2. Okay. That is B cell leukemia type 2 cell. You know, it's a B cell. And it's really, the BCL2 is a type of protein. It's a type of protein that has anti-apoptotic effect. Like apoptosis. Okay. It has anti-apoptotic actions or effect. So it's like a little protein. And of course, if you inhibit the antagonist, then you will have what? More apoptosis, programmed cell death. So the cancer cells will die, basically, if you inhibit BCL2. And that's what that Venetolax does. So it can be used in combination with RC, and Venetolax can also be used in combination with your azacitidine and your decitabine. You can use it that way. You can also, these are all for the management of acute myelocytic leukemia. These are different options you have, you know. There's a product called Glasdegib. Glasdegib can be given in combination with RC, and sometimes it is even given in combination with your Venetolax. for the treatment of acute myelocytic leukemia. Okay. Can be used for AML also. Glasdegib is a product that inhibits a type of receptor or protein that is involved in translation of cellular division. There's a certain protein that is called hedgehog. Which is involved in cell-to-cell communication. Okay. So Glasdegib would eventually inhibit this hedgehog pathway, transmission or translation pathway. And that's how it works, and it's used for AML. You also have sonidegib, but that's not used in AML, but it affects that hedgehog pathway, just like Glasdegib. Also for bismodegib. But these two are not used for AML. They're mainly used for BCC, basal cell carcinoma. But Glasdegib is used in AML. Other agents you can see used for AML. There is what you call the 7+3 regimen. 7+3 regimen is a combination of ARA-A, not ARA-C. ARA-A plus daunorubicin. ARA-A plus daunorubicin. That's the 7+3 regimen. That's a regimen that is called the flag regimen. Flag regimen is fludarabine, which you see here, under your purine derivatives, fludarabine. So we have fludarabine, that's the FL. And you have your ARA-A, okay, ARA-A, and then the G is a colony stimulating factor, GCSF, that is granulocyte colony stimulating factor. That's also used in AML. You also have CLAG-M. Okay. The M there is mitoxantron, which is one of your alkylating agents. And the CLAG, the CL, is cladribine, which you will see up there under purines. Up here, number 14. So cladribine, and then ARA-A, not ARA-C. Okay, ARA-A, and then your GCSF, and then plus mitoxantron. All of those are used for the management of AML. Okay. So we've basically touched on what we want to do here. So that's area A. We've got the indications there. 6-TG and 6-MP, 6-thioguanine and 6-mercaptopurine. Those are also just used for leukemias. You can use them for acute lymphocytic leukemia, ALL. You can use them for acute myelocytic leukemia. And then you can use them for chronic granulocytic leukemia. So those two are effective in those forms of leukemia. 6-MP, that is 6-mercaptopurine, is sometimes also used for the induction of remission, not to treat, but to induce remission in a patient that has ALL, acute lymphocytic leukemia. Okay, so we talk about the M&M regimen, 6-mercaptopurine plus methotrexate, M&M. You know, the M&M regimen can be used for induction of remission in a patient that has acute lymphocytic leukemia. Nelarabine is mainly used for one thing and one thing only, and that is pediatric ALL, acute lymphocytic leukemia in little babies, pediatric ALL. That's what you use nelarabine for. Clofarabine is used for two things, AML and ALL. So you see many of these purine derivatives are used in some form of leukemia. Okay. So clofarabine is used for AML, acute myelocytic leukemia, and acute lymphocytic leukemia. Then we mentioned fludarabine in FLAG, but fludarabine can also be used in the treatment of ALL. So you can use it in ALL and AML. Okay, that's your fludarabine, and it is also helpful in the treatment of non-Hodgkin's lymphoma. You can use it in non-Hodgkin's lymphoma, and in chronic situations, that is in CLL, you can also use fludarabine. Okay, so for fludarabine, you're talking about CLL, AML, ALL, and non-Hodgkin's lymphoma. Okay, so that's all of these. Cladribine, cladribine, apart from the clad M there, cladribine is also effective in the treatment of old cell leukemia. Old cell leukemia is also sometimes called hairy cell leukemia. And old cell leukemia or hairy cell leukemia is extremely aggressive. It is, anytime it occurs, you're always thinking of the life of the patient. Very, very deadly type of condition. In fact, before cladribine came on the market, there was nothing you could use to treat old cell. You can just give the patient some maybe some immunosuppressive agent that could just be palliative, or interferon. You can use interferon. But when cladribine came on the market, it was like, hallelujah, we have something that can at least address that deadly situation. But apart from cladribine, pentostatin, which is 2'-deoxycofomycin, I listed it up here. That can also be helpful. Pentostatin. That can also be helpful in hairy cell leukemia. Okay. If you look at the other indications for pentostatin, it is effective in other forms of leukemia apart from old cell leukemia. It can also be used in acute lymphocytic leukemia. It can be used in ALL, and it can also be used to treat CTCL. And we've mentioned that before, cutaneous T-cell lymphoma, CTCL. So you can use that pentostatin to treat that condition. Let me just mention one last thing about that cladribine. Some people have RRMS, which is muscular sclerosis. Relapsing, remitting, MS. That agent, cladribine, also seems to be effective in the management of that multiple sclerosis. So, okay, I think we've covered all the anti-metabolites. Okay. All right. So we can now finish up with the analogs of folic acid. So before we even get into it, let's so we're going to use methotrexate as representative agent. And let me just cross out raltetrexate. Didn't make it good in America, so we don't have to talk about it. Nolatrexate. It was very promising for liver cancer, but somehow it didn't make it in the US. Egatrexate, we can also cancel that out. Okay. So basically we're just left with methotrexate, which we're going to use as the representative agent, ramitrexate, pralatrexate, and pamitrexate. So ramitrexate, we know that that can be used for toxoplasmosis. We mentioned that before, toxoplasmosis. It can also be used in the management of PCP, pneumocystis carinii pneumonia infections. And it is also useful in your non-small cell lung cancer, NSCLC. So it is useful there. It is also useful in mesothelioma. So ramitrexate can be used in those conditions. colon cancer is another indication for trimethoprim. Okay, so we can rub those off. Okay, rub this off. Okay. Pralatrexate is only used for PTCL. Peripheral T-cell lymphoma, PTCL. So that's all that is used for pralatrexate. Okay. And pemetrexed, the last one there. And you notice the difference between XED versus XATE. So this one is pemetrexed, XED. Okay. And pemetrexed is used for cancers that are related to the pulmonary system. So you use it for that mesothelioma, the one that we said MPM, malignant pleural mesothelioma. Use it for that, and you use it for non-small cell lung cancer, NSCLC. Okay. So that's what you use pemetrexed for. Okay. And all of those have the same mechanism of action as your methotrexate. So they will be inhibiting your de novo synthesis of nucleosides, and they will be inhibiting dihydrofolate reductase, DHFR. Okay. In addition, that pemetrexed, the last one that we mentioned, is very effective in inhibiting thymidylate synthase also. So not only does it inhibit DHFR, it also inhibits thymidylate synthase, just like 5-FU. And then it would inhibit the de novo synthesis of your nucleosides. Okay, so we can finish up with your methotrexate. So just carry through. So with your methotrexate, we know the mechanism of action. So it will be three of them. It will be dihydrofolate reductase inhibition. It will be de novo synthesis inhibition, the de novo synthesis of nucleosides, and then a metabolite of MTX can do what we said pemetrexate would do, that is, would inhibit thymidylate synthase. That's a metabolite of MTX. That is the polyglutamate. The polyglutamate of your MTX can inhibit thymidylate synthase. So the three mechanisms of action for methotrexate. So that's the mechanism of action. And ADME, we know that methotrexate can be administered administered orally, and it can also be given IV, and it can be given IM. One of these has to work. Let's see. IM, and it can be given IT intrathecally, and it can be given IA intra-arterially, that is into the arteries, not veins. So those are the routes of administration. Of course, when it is used for cancer, it is basically administered intravenously. When it is used for things like, say, rheumatoid arthritis, or for Reiter's disease, or for PTCL, or CTCL, it can be given orally in those situations. So those are the routes of administration. Effect of food. Food will decrease the rate of absorption of methotrexate. But even with that, you still have to give the drug orally because it affects the GI tremendously. It's primary TLT, it's hemorrhagic enteritis, so it damages the GI tract. The second one is bone marrow depression, so it has two TLTs. Hemorrhagic enteritis and bone marrow depression. Okay, so food can decrease the rate of absorption of MTX. Okay. In terms of the half-life of that drug, it has a triphasic half-life. Triphasic half-life. The initial half-life is 3/4 of an hour. So it has 3/4 of an hour, and then the second one is 3 hours, and the third one is 10 hours. So it has a triphasic half-life. And when we look at its PPB, or plasma protein binding, that's about 50 to 60%. Okay. So even though it is relatively low, methotrexate does not cross the blood-brain barrier readily. It does not cross the blood-brain barrier readily, and that's why you see that intrathecal administration, because it doesn't cross the blood-brain barrier readily. In terms of the metabolism, the drug can be metabolized to a 7-hydroxy form. So you can get 7-hydroxy methotrexate. And that goes on in the renal system, not in the liver. So it's renal metabolism. Give you that 7-hydroxy methotrexate. enzyme that does that conversion is that aldehyde oxidase. That is also the enzyme that you find. This enzyme is also present in the liver. That's also the enzyme that is involved in the metabolism of cyclophosphamide. You know, and you know, for cyclophosphamide, any enzymatic pathway does not lead to activation of cyclophosphamide. The activation of cyclophosphamide is through non-enzymatic pathway. Okay. So it can be metabolized to 7-hydroxy. And the problem with that 7-hydroxy formulation, metabolite, is that it is the metabolic product that is responsible for the adverse effect, for the renal adverse effect of methotrexate. Okay. So you have that, and then you have the metabolism that is carried out by your microbial agents in the GI tract. So there's a small part of methotrexate, especially when you give it orally, that will be biotransformed by your GI organisms. And then you have the polyglutamates. And the polyglutamates, those are the ones, MTX polyglutamate. Those are the ones that are formed through the actions of polyglutamasis. We usually say polyglutamasis, if you want the full name. Polyglutamasis. And the enzyme will give you your methotrexate polyglutamase. And methotrexate polyglutamase is the one that can inhibit mediate synthase more so than your dihydrofolate reductase. Okay. But the moment this is formed, the polyglutamate, it can be hydrolyzed back to MTX. So you can have your hydrolysis that will convert the polyglutamate back to your regular methotrexate. So all those are happening in terms of the metabolism. And in terms of the excretion is primarily renal. Okay, so it's primarily renal, but some can go out in the feces and some can go out through your biliary system. Go out like that, and through the breast milk. So you have the breast milk, you have the fecal pathway, and then you have your renal pathway for the excretion of your methotrexate. Okay, the indications. Well, let's skip that because we will be talking about some combos. Let's go to the adverse effects. TLT, we've mentioned those, hemorrhagic enteritis, and your bone marrow depression. Bone marrow depression and enteritis, gastroenteritis. Okay, so those would be the TLTs. The other possible adverse effects can include pulmonary adverse effects. That's something called the methotrexate pulmonary disease. Methotrexate pulmonary disease. So it can affect the pulmonary. So if the patient on MTX is having some dry cough, that's the first signal. You know, they will have that dry cough, and then respiratory distress, and they may have COPD, you know, along with that. And that's not usually easily reversible. You know, once it happens, it can stay around for a while. So that's pulmonary. Okay, and can we talk about the ones that are related to the CNS? For the CNS adverse effects, you can get leukoencephalitis. Leukoencephalitis. And then you can get arachnoiditis. This leukoencephalitis can occur by itself, or it can be a manifestation of arachnoiditis. You only get arachnoiditis from MTX when you administer it intrathecally. Okay, that's when you can actually get that arachnoiditis. The manifestations of the arachnoiditis can include, like we said, leukoencephalitis, and it can include headaches. It can include stiff neck, and stiff neck you will refer to as nuchal rigidity. Rigidity, that's stiff neck. And then it can include paraplegia. The patient may actually become paraplegic as a manifestation of that arachnoiditis. So those are your CNS related adverse effects of MTX. Then cardiovascular, usually the same thing, angina, MI, and arrhythmias. All of those have been reported with your methotrexate. Okay. In the liver, of course, you can see an elevation of the hepatic enzymes, ALT, ST. Those can go up. Bilirubin can go up. You know, and if you use MTX over a long period of time, then you can get fibrosis and cirrhosis of the liver. So fibrosis and cirrhosis of the liver you can get with long-term use of your methotrexate. methotrexate. GI we mentioned as the TLT, but you can get your regular, you know, not all the way to hemorrhagic enteritis. You can get your nausea, vomiting, diarrhea, and you can get stomatitis, and you can get gingivitis. That is so that will be inflammation of the gums. Okay. So it can go all the way to that. And of course, you can have an effect on the skin, adverse effects on the skin. Will be the usual again, rash, alopecia, photosensitivity can be seen with that drug, you know, itching, pruritus, dermatitis, all of those can be manifestations on the skin. And then the drug can be teratogenic, it can be mutagenic, okay, it can be teratogenic, it can be mutagenic, and it can be embryotoxic. It can affect the embryo of the female. And so if you put all of those together with the fact that the drug has some anti-inflammatory effect, or you know, suppression of the immune system, then you can see why that drug can also cause cancer. So it's used to treat cancer, but it can also cause cancer. It's mutagenic, it's embryotoxic, and it suppresses the immune system. It's an immunosuppressant. That's why you can use it in rheumatoid arthritis. Okay, so it can be carcinogenic based on those actions. There are some minor things that it can also produce, your fever and the muscle weakness. It can also produce some of those. All right, for indications, you have some non-cancer situations in which you can use methotrexate. Mention one, rheumatoid arthritis, because of its immunosuppressive effect. That's one. Two, can be effective in managing CTCL. CTCL is cutaneous T-cell lymphoma. And that's the one that is also called mycosis fungoides. Okay. Mycosis fungoides, CTCL. Okay. And we mentioned another drug that you can use for CTCL, pentostatin. Remember the one that would also be effective in oat cell or hairy cell leukemia. So mycosis fungoides or CTCL. It can also work in Riders disease or Riders syndrome. That is a condition that is usually found in young men, basically, and they will get some inflammation in the eyes and stuff like that, increased susceptibility to infections and things So it can be useful there. And one may also use your methotrexate to procure abortion. So that's another possible indication for your methotrexate, as a non-cancer indication for your MTX. Let's quickly deal with another thing here. It has also been shown to be effective in the management of PCP, pneumocystis carinii pneumonia. So when it comes to cancer, for methotrexate, you can talk about choriocarcinoma. Choriocarcinoma, one. You can use it in mole, particularly one that is called hydatidiform. Hydatidiform type of mole. So you can use it there. In acute lymphocytic leukemia, of course, it is also used in head and neck cancer. You can use it in Burkitt's lymphoma. Burkitt's lymphoma. We can use it in breast cancer. It used in cancer of the bladder. Then you can see it in non-Hodgkin's lymphoma. Hodgkin's lymphoma. Got about head and neck there. Okay. Breast, bladder, head and neck. So these ones we've already talked about: breast, bladder, head and neck. Take those out. Okay. There's a regimen that is called the hyperfractionated CVAD regimen. Hyperfractionated CVAD, there are two of them, hyperfractionated CVAD A and then CVAD B. Okay. That regimen is used for the treatment of acute lymphocytic leukemia, okay, and it's also used for non-Hodgkin's lymphoma. So you can use it for those two. If you look at ALL, like we said, you can use the M&M regimen to induce remission. So 6-mercaptopurine and methotrexate to induce remission. Okay. One may also use the VAD regimen to induce remission, okay, which will be your vincristine, adriamycin, and then you have dexamethasone. So one can use that VAD regimen or use the M&M regimen to induce remission. But for treatment, you can use the CVAD, okay, which would just basically mean adding cytoxan or cyclophosphamide to the VAD, cytoxan regimen. The CVAD-B is your CVAD plus. So CVAD-B is actually CVAD-A plus methotrexate plus RC. Okay. That's really what your CVAD-B is. And you alternate every 21 days. Every 21 days. So you use CVAD-A for 21 days, then the next 21 days you use CVAD-B, and then you come back and use CVAD-A, every 21 days, like that. So that can be used for your ALL treatment and also for non-Hodgkin's lymphoma. There's a regimen that is called MIE, which basically is mitoxantrone. That's Novantron. Okay. That's Novantron. So mitoxantrone, then a phosphamide, and then etoposide. That's also used for the treatment of acute lymphocytic leukemia. So one can use those regimens for your ALL. And since we mentioned those, here it is ALL. Okay. Burkitt's lymphoma, you can use a combination of methotrexate, plus RC, and then plus your cyclophosphamide and plus your Oncovin, which can be used there, and you can add, say, doxorubicin also to that regimen. So that regimen is used for the management of Burkitt's lymphoma. Okay. And if you recall from the antiviral lectures, okay, your Burkitt's lymphoma can be caused by one of your herpes virus members. So that one. You may see that as Marcoa. Okay. That is methotrexate, RC, and then cytoxan, oncovine, and adriamycin for Burkitt's lymphoma. Okay. And then lastly, we see the choriocarcinoma and hydatidiform mole. The regimen that you use for choriocarcinoma is the same regimen that you use for hydatidiform mole. Okay. Hydatidiform mole is a gestational type of cancer that develops from the cells of the womb, from the uterus, cells of the uterus. That's where it develops, and it just keeps getting larger, and the patient might think that they were pregnant. That's why it's sometimes called pregnancy mole. It's just that 9 months come by and there's no baby. So, and that's a serious type of cancer. Choriocarcinoma, that basically comes out of the cells of the placenta. The placenta cells are the ones that will detach and go and lodge somewhere else in the reproductive system of the female, and then will start growing as a cancer. Extremely deadly, very, very aggressive type of cancer, choriocarcinoma. And choriocarcinoma can be treated well. We have better regimens now. In the past, it used to just be high dose methotrexate. That's all you can use, and you'll see it as HDMTX. And that HDMTX is also the combination regimen. It's not really a combination because it's just high dose of methotrexate. If you're giving a high dose of methotrexate, you want to add leucovorin along the way somewhere to prevent normal cells from being destroyed. Okay, but this high dose methotrexate you can use also to treat bony sarcoma. Remember when we were talking about your cyclophosphamide, we talked about some soft tissue sarcoma, like leiomyosarcoma, rhabdomyosarcoma, liposarcoma, fibrosarcoma, all of those. Those are soft tissue sarcomas. But there is a type of sarcoma that develops in bones. That's the bony sarcoma. That's not a soft tissue sarcoma. But you can use high dose methotrexate for bony sarcoma. And Cyberdick that you used in those soft tissue, that is DIC. So cyclophosphamide, vincristin, adriamycin, and dacarbazine or DTIC. That cyberdick can also be used in some instances to treat bony sarcoma. So, but to see the combos that are used for these two, you can talk about Emma Co. MCO, and then EP Emma. Use those, and then you have your PE itself, and then PT or TP, reverse those. Okay. Of course, P is platinol, your cisplatin that you can use with etoposide, and then PT can be platinol plus one of your taxanes, that is like Taxol, that you can use. Okay, so P is the same here, platinol, etoposide, and then Emma is etoposide, methotrexate, and then you have your dactinomycin or actinomycin D. That's that A, actinomycin D, and actinomycin D is dactinomycin. So you can use those. And then EMA is the same here, Emma, and then you have your cytoxan and oncovin, so cyclophosphamide and your vincristine. So those are the regimens that are used, and you always alternate so the first 7 days you can use Emma, then the next 7 days you use CO. So you have 7-day alternating regimens. And for PE Emma, first 7 days you use PE, then next 7 days you use Emma. And then you start back with the PE after 7 days, and then after that for 7 days, then you use Emma. So those are the regimens or combination regimens that are useful, and like I said, those are used for both choriocarcinoma and hydatidiform mole. Okay, questions? Everybody still awake?
Mm-hmm.
Okay. All right, well, you have the AOC to get you started, and during the review, we'll basically come up with some questions that will cover some other things.